Awesome. All righty. So I will just quick do my introduction. My name is Scott Suter. I'm an endodontist out in Reno. I have my own practice that I started in 2020. I primarily am in private practice, but I do a few other things, which we'll go through real fast. So I do teach at St. Louis University. None of the things that I'm saying today will be associated with them. I also am involved at multiple levels with organized dentistry, and all the other stuff is the normal disclosures. This is being sponsored by Healthy. I want to make very clear, I'm not getting financially compensated by this at all. I like their products. How this all started is I do have a small little YouTube channel and people recognize me from that, and I use their products there. And a bunch of people were asking me, which ultrasonic tips to use, blah, 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 blah. And so at the last few AEs, I've been going over there and have inadvertently become one of their best salesmen because I like their products. I did get a few samples from them at no cost today, so I do want to just make everything very apparent here, but I'm not getting paid. Do what you guys want. I'm here because I like their products. How many of you have seen my YouTube channel? Anybody? Here is the QR code for that if you are interested. At the end of the presentation. Yeah. At the end of the presentation, I will have a screen where you guys can take a picture of all of it. It has all the conclusions from the presentation, plus this, plus a few of the QR codes. Take one picture, you can get access to everything at the end. But I try to make it that you guys have easy access to all of this. I will make this presentation available to you all as well. That way you'll have it. So ultrasonics, why are we here? What are we talking about for them? The first thing, and I should probably back up. The way that I like to give presentations is very free flowing. If you all have questions, please shout them out. I know we're a little short on time, so I'm going to go through things a little bit faster than normal. But if you have questions, I want to answer them in the moment. And what I try to do with all of my presentations is talk about what I wish I knew when I was in your shoes. So I assume I'm talking to residents of a couple different years, some who will be finishing in a few weeks and some who are, just about a year through their process. And I'm going to start off with the few things I wish I knew. The first thing is how to actually figure out the power that you should be using these at. Thankfully, Healthy already has a video on this, and it's a very, very useful tool because depending on what unit you have and depending on what tip you're going to use, the proper power setting is going to be different. So I can tell you what I use on mine, which is a Sadillac unit, but if you're using something from a different company, it's probably not going to be the same. So it's more important to customize it based on what you're going to be doing, and that's where this QR code comes in. Once again, this will all be available at the end on one slide you can take a picture of. So talking about coatings, there are two primary coatings you have on ultrasonic units. You have either completely smooth or you're going to have diamonds. There are some that uses carbides or a little micro etching on them, which are kind of cool. But in general, you're going to have either a completely smooth coated one where there's nothing on there, or you'll have diamonds. Pretty much diamonds are great because they're more aggressive, but they're also more aggressive. So if you're troughing and you're in the wrong angle, now all of a sudden you're going to have a problem a lot faster. So when you're starting off, it's probably better to use something that's a little safer, like an uncoated one. And as you gain your skills and learn what you're doing, you'll get frustrated by the uncoated ones and switch to diamonds. I have a box of ultrasonic tips that has probably 40 different ones in them, and I probably have 30 different surgical tips because you just kind of accumulate them over the years. I have my very favorite ones that I use all the time, and then I have a random assortment of stuff that you pull out for cases when you least think of them. So as we talked about, diamonds are going to be more aggressive. Big thing here. You guys all should have a wrench or a chuck or something to put the actual tip onto the handpiece itself. We all have strong hands. Don't do it by just doing your hands. The way these tips work is they're going to transmit the vibration through the unit itself into the ultrasonic tip, and they transmit it through that little threading thing. And if you do it by just doing your hands, you're going to lose a lot of the power. So you want to use the wrench, and it's really, really important to train your assistants to use the wrench to remove it as well. Because I have seen many, many tips break because assistants think they can just twist it off like they would with a lure lock, and they don't realize they need to use the wrench. So we keep these little wrenches. The Healthy ones are adorable, by the way. These are the ones they sell. They're these like little tiny, cute little wrenches that looks like a Lego that I would use. But it doesn't matter which one you use. They're all pretty much the same. Just make sure you use the wrench to put it on and put it off. Ask me how I know. I've had quite a few ultrasonic tips break because assistants didn't do it properly. There are two different types of threads. You have the S thread and the E thread. S thread is for Sadilac. That was one of the first ones to do it. That's also the one that just happens to be on my ASI cart. Most of the ones made in the United States are going to be S thread. Most of the ones overseas are going to be E thread, but there's a mixture. If you don't know which one, call the company, say, here's my unit. Which one should I do? But you got to make sure the threads are correct. Otherwise, it's not going to fit. Not many of you are going to be able to do this right now because you're in residency. However, when you get out into the real world, if you have the ability to build your own office, I highly, highly, highly recommend having 2 ultrasonics. The reason why is you'll see even when I'm going to show a video at the end of me using the ultrasonics in a case, you want to be able to switch between the 2 different ones. And if you have to undo them and redo them every single time, it's going to get annoying very, very quickly. The other nice part about using a cart like this, not sponsored by ASI or anything, I just really like using them, is all 6 of these units. Where's my mouse? All 6 of these hand pieces. So this is actually my unit. I have 2 air high speeds, 1 electric, 1 air low speed, and 2 ultrasonics. All of these are controlled by the same foot pedal. That makes it very easy to just swap between. I remember in residency, we'd have like the foot pedal for the ultrasonic, and then you'd have one for the handpiece, and you'd have one for the endo handpiece, and you'd accidentally hit one and it would spray all over. That's very annoying. If you can make it that it's just the single one, do it, and make sure you get 2 ultrasonic tips because it's going to make your life a lot better, and you'll be more likely to actually use your ultrasonics. Now, there are many, many, many uses for ultrasonics in endo. I don't think I need to tell you all of these, but I do want to go through a couple of them. There are a few ways that you can use it to remove restorative material that's, I think, superior to traditional high speeds, which is very nice. Obviously, separated instruments. I'm going to show you an example of how I trough for it. Calcifications, pulp stones, obviously that's a super useful one. There's a great toy that they have for Gutta-Percha removal that is I just started using, and it's absolutely wonderful. You can also use it to obturate. If you guys remember back for lateral condensation, you would actually use an ultrasonic to kind of vibrate inside there and condense the Gutta-Percha. Obviously with post, best thing ever. Irrigation, before all the advanced irrigation came out, this was the only option we really had. You can condense restored material, place MTA. They're useful for trauma cases, canals, and then for surgery. At this point, I do have an Air Impact 45 that I put out for every surgery, and I use it about 1 out of every 10 times because I'm using ultrasonics only for all of it. And I almost wish I had a third ultrasonic just for the surgery, but that's a different thing that's just for me. But you can now use it to create the hole in the bone. You can resect the root with it. That's my very favorite tip, and that's actually probably the one that I brought over more than anything else was the Blade Sonic. But I was told we're not doing surgery today. We're doing the more traditional stuff. You can use it to prepare the root end. You can help fill it. And then the one thing I want to remind you all, ultrasonics are really good at removing calculus. And I know we're endodontists and we do root canals, but when you see that case that comes in and it's coated in crap all around the outside of the tooth, don't you think your root canal probably has a better chance of healing up and the patient's going to feel a little bit better if after you get them numb, just quick go in and zap it off? I actually have scalar tips in my room. I run it at a pretty low percentage because you don't want to cut anything. And it's really, gum tissue is really easy to get numb, you guys. Like, how many of you have had problems getting the gum tissue numb? You have problems getting the tooth numb, but not getting the gum tissue numb. So after you give your anesthetic, while you're waiting for that to kick in, quick take the tip, clean off the calculus. Takes no time. You're not really, the patient's going to be happy because they got a 1-tooth SRP. It's going to make things a lot better. So I did want to throw that in there I still do. I have scalers in both rooms, and I have ultrasonic tips for scaling in both rooms too. And it is a very useful tool for that. Okay. So, we're doing great on time. Good. These were the 3 things I was told you all were interested in today, is dealing with calcifications, and I take this to mean kind of finding MP2, as well as troughing apically through calcified teeth, how to use these for retreatments, and then how to remove post. Does this sound right to everybody?
Yeah.
Cool.
Yes.
I also needed a sip of coffee, so that's when I ask questions, is when I need a sip of coffee. All right. For calcifications, this is my number 1 favorite tip by far. It is the E2D. I have probably 20 of these. I order them in bulk because I like them so much. Now, this tip is cool for a couple of different reasons. It's very thin, so you don't have to remove too much tooth structure. It has an active diamond tip right here at the end, which allows it to be aggressive. And it's not too sharp. Oftentimes when you're troughing, you want to avoid creating too sharp of a point in your trough, because when you go back in to peck with like a 6C or an 8C, you can often get a false stick because the tip is too sharp. This is a little bit more blunt, which is nice, and I'll show you how I use this plus a combination of the rotary or the high-speed handpiece when I'm doing my troughing to make it as accurate as possible without having to remove too much tooth structure. The other cool thing about this is these will break eventually. The beautiful thing is that when they break right here. Doesn't this still look like a very useful tip? So I'm definitely frugal when it comes to buying stuff for the office, and this is one of the reasons I love this tip. Is I kind of get two uses out of it, because now when I have it, the diamond part pops off. I have a slightly shorter one that I can crank up to 100, and I use this to remove amalgam cores. You can actually put it in there at 100, and it will just vibrate out amalgam. It like melts it. It's actually incredible. You can use this for post removal. You can use this for anything where you wouldn't really want to use your nice, pretty new files because you don't want to break them. And since it's already broken, it's not going to break again. I've never actually had one of these break again. I probably have like 4 or 5 of them in each room because they've broken over the years and they just never break again. So it's still a useful tool after. And then the other one that's really useful for calcifications is this E15, which they call the finder. This one is shaped kind of like a pear-shaped diamond at the apex, but it's much, much smaller than a traditional diamond. And one of the big benefits of using ultrasonics is that because you don't have the gears to spin like a burr, which you would for a high speed, you can see. And so I know I know my residents at St. Louis really go towards ultrasonics rather than using high speeds or something like a Munspur because they're able to visualize it a lot better. And as you gain skills, you'll learn how to use it and manipulate the mirror. But when you're first learning and everything's hard, this makes it a little bit easier because we spend all this time and money learning how to use the microscope. And then we put this big old head inside there and you can't see anything around it. That's where ultrasonics are nice, is because you can actually see. So the E15 is something that I'm going to use if I'm really far down in a tooth, if I'm troughing for like an MB2, 15 millimeters down, or if there's a broken file, you can kind of just pop it with this and it usually pops out pretty easily. Another useful tool, but the number one that I use all the time is the E2D. My staff doesn't know any of the other numbers, but they do know the E2D because I call that one for name because I use it so much. It's a wonderful, wonderful file. Now, how do we use this? And really, we're going to be talking about MB2s. I think this is mostly what people struggle with, is how to find MB2s. And by learning how to find the MB2s, you'll also learn how to deal with calcified teeth at the same time. So when we're dealing with MB2s, this is a case I did. It was a retreat. And the reason I like this is because it's very easy to see. You can see these canals were definitely prepared much larger than I would do normally, but it makes it easy to see the symmetry. And then you can see where MB2 is. So for maxillary molars, what I recommend doing is finding your 3 main canals. Generally, these aren't going to be as hard: your palatal, your MB1, and your distal buccal. After you do that, I want you to open them up slightly, and we'll go through the whole process. You guys can take pictures of it. I have it all written out for you. You want to open it up so it's a little more easy to visualize. And then in your head, you're going to draw a line from the MB1 to the palatal. Then also in your head, you're going to draw a curve that runs along, and it's usually about 1 to 2 millimeters mesial to that line. Your MB2, 99% of the time, is going to be somewhere along this line. Sometimes it's right here. Sometimes it's smack dab in the middle. I've had them come off and join up with the palatal. MB2s are wildly variable. Also, for those of you who haven't seen my video on MB2s, I did an informal little study. I take pictures on every single patient. And so I was wondering, okay, how many MB2s are there actually? And so I went back and looked at the last 100 maxillary molars that I did. How many of them do you think had MB2s? What would Vertucci say? A little louder, I can't hear you guys.
About 60. We have 60. I have 94.
94? Okay, 60, 94. That's a pretty big variety there. All right, I'll tell you my number. 92 of the 100 had an MB2. 7 of the 100 had an MB3. There's only one tooth of the 100 that had a single MB. So it's pretty much always there. And even if it's not there, there's probably going to be a third canal that you need to find. So that's a really, really important skill to learn. If you want to pay off your loans, learn how to find MB2. It's a really, really good skill to learn. So how do we do that? Feel free to take pictures of all of these. None of this is copyrighted or whatever. So locate your MB1, your distal buccal, and your palatal first. I then use an orifice opener, and I like to use the VT series. I use the Brasseler ones, but it's a 2006. I take that down about halfway to where my length is, and that makes it so that the hole's a little bit bigger. And all I'm doing there is just making it so I can visualize it a little bit more easily. I then draw that line from my MB1 to the palatal. Your MB2, oh, I'm echoing now. I'm going to mute this one. Can we mute that other phone? Because I'm echoing now. There we go. Thank you. MB2 is going to be along that line about 1 to 2 millimeters to the mesial. And generally, it's going to be within about 3 to 5 millimeters of the MB2 along that line. So there's your rough strategy for the anatomy. How do we find it? So I like to use a combination of the E2D, and then I use a skinny diamond. I use an 850-012 super course. And by switching between those two, I'm able to create a trough very accurately along where the line is. And then I can follow it up with that diamond if I don't get it, to make it slightly wider, and it's more accurate because I can follow the tip, that the line that the diamond made. And I like to use no water on this one. You're not going to be creating a lot of heat because it's a very gentle process, but I want that dust to accumulate, because after the dust accumulates, you come in and you air dry. Don't use any water for this. If you haven't used a Stropco tip, they're really, really useful. You can get them for like $20 on eBay. You don't have to get the actual ones. Buy it now, use it in residency. You just put a little, they're all lower lock, so you can use the etch tip in there. Everyone I've talked to who I've told to use one of these says they will not go back to using a regular air water syringe. It's worth $20. Go order one on eBay. I promise it'll change your life. But if you have an air only one, which I do recommend having on your cart as well, it works nicely because you don't want the water spraying in there, because it kind of, makes it a little harder to see. But you want to look for signs of dust accumulation. You're usually going to see those either along the line, or you're going to see it in the actual hole where the MB2 is. Sometimes if you can't find anything, EDTA is useful because it chelates the calcium, and so it's going to pull out anything extra, dry it really well, and then you'll be able to see that line in addition to that. But what you're going to look for is a discoloration, and usually it's going to be white if it's a calcified case. If it's one of the more like normal cases, you'll usually see a darker line that's going to kind of go and show you where the MB2 is going to be located. You're going to follow those lines with a combination of the E2D and the skinny diamond. And I only go about 0.5 millimeter apically each time. You don't want, I'm not drilling down 4 millimeters at a time. Gentle brush strokes, repeat. Once you've found it, you want to feel for kind of like a stick. And so I think you've all felt this, but if not, you don't want to feel like you're pushing into something hard. It shouldn't feel like you're pushing into the tabletop. It should feel like you're pushing into a piece of rubber, that there's like a little stick that goes inside there. Once you get the stick, you're going to open up and you'd use the normal combination, 6, 8, 10, sometimes get up to a 15 until you're about 3 to 4 millimeters deep. Once you're at that point, you want to rinse with EDTA. As a reminder, hand files compact debris. Rotary files remove it. So if you've used a lot of hand files, make sure before you put anything in there, you're rinsing with EDTA to remove any of the debris that you push down inside there. And then I like using really skinny files. This is also within the Brasseler family, but they're the original SS White V-taper ones. The 1403, the 1704 are really useful to start that initial process of negotiating down. And you want to feel for that stick. As far as how much pressure you're putting, it's very little. I don't put more pressure apically than the amount that would take to bend the martensinic files. So if you look at a 13 or a 14 rotary file, that's not a lot of pressure. You're actually just letting the file do the work itself. The weight of your actual handpiece is all that you really should need to move down there. Once you've opened it up to that about 3 to 4 millimeters, you want to switch to a different taper, because that different size taper is going to make it that it works in a different area in the canal. And really, with all rotary files, we want to make sure that we're engaging small sections at a time. You don't want it to be that the entire file is engaged, because that's how we break things. You want to change up the tip size and the taper size every time you use a rotary file, so that you're working on different parts of the canal as you work your way down. EDTA is a great one to rinse between here if it is a calcified case, because it softens it. Do be careful, because you can create your own canal. So don't push here. Like I said, very gentle pressure with all of this. And then I go back in with an 8C. Oftentimes after doing this 1 or 2 times, it gets right to length and it's good to go. If you don't know how far the tooth is, if you don't have a cone beam to measure off of, it can help to get length of the MB1 beforehand. So you know, okay, my MB1's 21. You know your MB2 is probably going to be within a couple of millimeters of that. The biggest discrepancy I've seen has been like 4. So if you're at 13 millimeters and MB1 is 21, well, you got a lot of work to do until you get down to actually being paid there. So with calcification, any questions as far as MB2s, the ultrasonics, anything like that? I'm gonna show a video of a case I did last Monday after we finished with this, so we're still good on time. Perfect. Okay. Calcifications, very similar strategy to the MB2. I take cone beams on all of my patients. I highly recommend you do the same thing. And I like to plan it out. And so I want to measure how far it is from the occlusal aspect down into the pulp. I want to measure between the canals. I want to measure how long each canal is. And that gives you an idea of what the tooth's going to look like. And it gives you the way to almost practice the root canal before you see it. That's why a cone beam is so valuable here. For most teeth, they're going to have some symmetry to them. And this does include maxillary molars. It's just a different type of symmetry. So this is where the palatal is. So you draw that line between there. And usually you're going to have the MB2 be kind of, if you made a perpendicular cross with the distal buccal coming along between the palatal and the MB, it's usually going to be right around here. The other thing I wanted to point out with MB2s and any calcified case like this, they move a lot. This is actually where the initial stick was. This is where it ended up. So the MB2s can move quite a lot. They can go mesially, they can go buccally. I've had them where they move a little bit mesial and they go back distally. And that's because in those first about 3 millimeters, if you look at the micro CTs of MB2s, they actually have like almost a zigzag pattern that they can do. They're not usually straight. That's why these are so difficult, is because they'll have these little curves in that first 3 millimeters. And that's why you need to continuously follow it as you're troughing down. Okay, Gutta-Percha. So at the last AAE, they told me about this. I had not used this tip before. And once again, I'm very frugal. I don't like buying new things because they're expensive. And I didn't want to like this one. And it works really, really well. I had a case about a month ago where I don't really tend to use a lot of chloroform in my retreats. I usually just use the B&L alpha, but it's similar to a system B. I use that to remove, that's heat to remove the Gutta-Percha, and then I go in with an F1 that I'm spinning pretty quickly, and that usually works for 99% of my cases. This one, though, the Gutta-Percha is it's an older retreat. It's like 15, 20 years old. It had some caries, needed a new crown, so we were redoing the root canal. And my tip went down like 2 millimeters. Like the heat wasn't touching it. It was super hard. And I was like, oh yeah, let me try this thing. This little bastard went straight to like, it worked so well. I don't like it when I like new things because I have to buy them then. So this is a very, very useful tool. You'll actually see it in use here in just a few minutes on the video as well. But what's cool about this is the tip. This tip is just like a little arrow, but it's barbed. And that's the really cool thing here. And so how you're going to use this, you place it in the Gutta-Percha, you activate it, and you're going to push apically. And this one you can actually push on a little bit more than you would with like a rotary file. And you don't want to have water, because how this works is it's using friction as it vibrates to heat up. It melts it so much better than chloroform or System B. It's absolutely insane. The cool thing here is because it is barbed, if you push it down in there, activate and get down to, about halfway down or wherever you feel comfortable stopping, leave it in there for like 5 seconds so the gutta-percha can start to harden. And then when you pull, you'll have this huge chunk of gutta-percha come out. It's a very, very clean way to do retreats. And that's the video that I'm going to show you guys in a few minutes. It does work well with Thermafil. Sometimes I've actually had it grab the Thermafil carrier out for me, which is just the best thing ever. Out here on the West Coast, we have a lot of Thermafil. I've seen... I've actually never seen a silver point case out here, but I see a Thermafil case once a week. So I'm very used to doing Thermafil, and this thing makes it a lot easier. And then once you've created that shape, you can then come in with your regular retreat pile. I use the heat-treated F1, and actually use SS Whites for that one. But any of the heat-treated ones, the F1s are a very good, all the Pro Tapers are very aggressive. They remove gutta-percha very effectively, and most of the time with retreats, the sizes are big enough that you're not going to be removing any more dentin. 4 posts. That right there is like an hour lecture on its own. This is a video that I made specifically on how to remove posts. So feel free to take a picture of this, go back and watch it at your leisure. But they're pretty, I know it's hard right now. Once you learn how to do them, most of the posts take me about 30 seconds to get out. So you can get these things out very, very effectively. Now, how do you do it? And that's the key thing here. What you need to do when you have a post, do I have something that's shaped? Okay. Water bottle. Here's my post. Okay. When it is in the tooth, it is held in place. Remember that usually you're going to have some space between the canal and where the post is. And in between that, you're going to have either composite or some sort of cement. Your goal is to remove the cement that's supporting the post without damaging the tooth itself. And that's where using something that's very thin and aggressive, diamonds, is a very, very useful tool. The first thing you want to do when you're removing a post is to remove all the restorative material that's above the pulpal floor. You can do this using diamonds, you can use your ultrasonic, you can use whatever you want. Just you guys all know how to access teeth. So just remove as much of it as possible until you hit the pulpal floor. Once you hit the pulpal floor, you're going to want to take something like the E2D and go around circumferentially, and you only have to go down a couple of millimeters because most of the time when posts are placed, if you use the ultrasonic, the vibration will actually break the composite loose. It's not like friction like you'd have from a high-speed handpiece. It's actually the vibration that will break the bond between the post and the canal, because C-factor is a thing and it's not very well bonded down there, and it pops it off really easily. What you're doing here is you're undermining the post. So now instead of all of this being supported, now it's just this. Then you get to use the big fat scary tip. So they sell one that's an E12. I did ask for permission to do this. You don't have to get the E12. You all have a broken buck one somewhere in that clinic, I guarantee. That's just this big fatty monstrosity of a tip. And 100% power, 100% water, don't kill the bone. And what you want to do is you're going to take that big fatty scary tip and you're going to push on it. It's not this, it's this. You're pushing in one direction. And you can push pretty hard on this sort of thing. You're not going to break the tooth this way, as long as it's not like a skinny, premolar. Then try it a different way. And what you're doing is you're transmitting the vibrations from your ultrasonic down the post farther apically into the area where you have the cement or composite holding it in place, which is then going to dislodge it. So when you want to be in the scope looking at it, and this is why the ultrasonics are so nice, is you can visualize it. You should be seeing cement popping off from down inside the canal itself. Then you can go back in with your E2D. This is why I say to have 2 ultrasonic handpieces, by the way. And you can go back in, go farther, and move apically. Most of the time, it takes me about 30 to 45 seconds to get a post out once I start the ultrasonics. So it is a very efficient way. I wanted to keep things, we only have 10 minutes left, so I didn't have time to do the entire thing, but I've got a video on that, and now you guys have that as well. I did want to do a small little, sometimes endo can be useful in the real world. We bought a house that's been very unloved for quite some time. And I wanted to plant a bush here for my wife. And as I'm digging, there's suddenly a giant cement post. No idea why. It's not like there was a sign here. They just, I feel like the people who had the house before us just wanted to mess with me. And so I realized, wait, I know how to take these out. I'm an endodontist. So I use my pickaxe, which is kind of like an E2D, to remove the supporting cement, which would be your dirt, around the coronal portion or top part of said cement. And then I'm still waiting for Halsey to make a Tacoma shaped tip. If you guys could do that for me, I'd really appreciate it. But I did feel like a fun redneck getting to pull this out in our kind of bougie neighborhood. My wife was not pleased with me, but we did get it out. And so there are other uses to endo besides just doing root canals. So this is the slide. I want you all to take a picture of these 3 QR codes on the right-hand side. Top one's to my YouTube channel. Middle one is to that power setting video that I talked about. The bottom one is to the how to remove a post video. Conclusions. Ultrasonics are required for a modern endo office. When I was doing a little bit of the research for this presentation, I came across a quote from Steve Buchanan from like 2009 being like, every modern endo office needs to use these. And that was 16 years ago, you guys. So clearly we got to use ultrasonics in every modern office. If you have the ability, get 2 hand pieces. It makes your life so much easier. Make sure you use the wrench, use the proper power setting. Diamonds are more aggressive. Use that to your advantage, but also be careful if you're not sure where you're going. Posts don't have to be hard. Watch this video, and if you guys have any questions, go for it. As you guys are all finishing up your residency or going into your second year, the one thing I like to tell all my residents is, and I'm going to give this lecture next Wednesday to them, one day, very soon, you're not going to worry quite as much about how to do root canals. I don't know of anyone who's at their 10-year mark out who still stays awake at night worrying about finding MB2. You will get there, I promise. Keep learning, keep staying hungry. And if you guys have any further questions, please reach out to me. You can feel free to take a picture of this. This is my cell phone. The best way to get a hold of me is to text me. This is my email. This is on all the socials. It's Patency Pro. Although I did realize I screwed up on my TikTok, but I don't actually have anything on there, so that doesn't matter. But any questions for me about all this while I pull up the video? Do I need to show the slides anymore? Did you go the pictures of them?
Yeah.
Yes.
Cool. So this is a case that came in the other day. She was having pain. You can see a little bit of a lucency here on the MB root. And sure enough, there's a missed MB2. I make this drawing all day long. I retreat a lot of MB2s. I did do a selective retreat here because the palatal had nothing going on. It looked fine. Both of the buckles did. I'm going to use gentle wave here, and I actually measure all my cases because with the gentle wave, I don't really actually need to get length because I also squirt fill. Much longer story about that. So I sped this up. You all know how to access through teeth, but people like to know what I use. So I use the zirconia diamond for Brasseler. That's like their Duracut, I think is what it's called. Here's that skinny diamond. That's the 850-012. This is what I use to remove the bulk of the composite. Once I get down, though, we're going to be using the ultrasonics now. And this is how I start to do the removal of the restorative material. The nice part about using ultrasonics when you're that far apical and you're at the pulpal floor, especially on a retreat, I don't want to take away any more dentin. I just want to take away the composite. And you can actually see how the way that this removes it, it's a little bit different than if you were using a burr. You can see the composite almost flake off in chunks. It's not abrasive. It's actually just the vibrations are making the bond from the composite to the tooth itself break. That's what's really useful here. It's also really useful for amalgam cores. I think I mentioned that earlier because I hate taking out amalgam cores. But you can see how the composite just pops off very effectively. So there's your first use, is removing restorative material. One of the best uses if you want to make sure you're very conservative and don't remove any extra dentin. You don't have this visualization and you don't have the tactile feel with a high speed like you would. Okay, we are now starting the process, and let me quick pause right there. What we're looking at here is where the MB2 is going to be. So remember I said there's going to be a line connecting to a white spot. So this white area here, I know our MB2 is going to be somewhere along here. This little hint of pink, that's where the MB1 that they found is located, and you can see the line. So what I'm about to do is take the E2D and connect these two. It's all just paint by numbers. It's drawing, the tooth tells you where you need to go, and you can literally just follow this area. So I know our MB2 is going to be somewhere right around here, and that's what I'm doing. Do this dry so you can see that dust accumulation and remove just about 0.5 millimeter. This is not an aggressive procedure. It's pretty easy to get this all taken care of here. And now we're going to be using that cool R1 to go down and remove the Gutta-Percha. It is pretty stinking impressive how quickly you can remove it. So you can see all I'm doing is activating it, and as it drops down, I'm pulling back out. So it removes a lot of the Gutta-Percha very effectively. And you can see just how much is coming. Look at how much came out just in that one chunk right there. And I can use it almost like you would like a headstrum to pull out the material. And so by the time I go in with my rotaries, the coronal portion of Gutta-Percha is actually pretty much gone. The distal buccal was a bit of a pain. It was more oval shaped, and so there was some that was getting pushed off to the side. So you'll see I have to go back a few times into the distal buccal. But as we do this, I need a quick sip of water. If there's any questions, please shout them out. Once again, didn't want to like that tip so much. But now at this point, we're going to be running the F1. I run these fast because you want to use the friction from the speed to melt the Gutta-Percha, and it's going to pull out the Gutta-Percha as you do it. So it's a very useful way to do it. I already have my lengths, so I measured beforehand. And as you get more and more used to doing this, you can feel when you drop bait, and you know what it feels like. That's right at the very tip. Sorry. The camera on my microscope, it's the same camera we're using here. It has a view that's slightly smaller than what I can see. And so sometimes when I'm at extreme angles, you can't quite see quite everything here. So I do apologize. Some of this did get cut off, but you get the idea. This removes Gutta-Percha very, very efficiently. None of this is sped up. The only thing I sped up was the beginning, and then I do the gentle wave here. So I do speed up a little bit of that there. But all of this is real time. So to remove all the Gutta-Percha, it took me about 4 minutes. It's not actually that long to remove it, as long as you have the right tools and you know how to use them and you use them effectively. And you can see at this point, we're pretty much to my working length on the MB1. I haven't even touched MB2 at this point. I'm just getting the Gutta-Percha out because I want to see where everything is, get that part done, and then you'll see me address MB2 here in just a second. The distal buccal was a bit of a pain. I will say that. I almost got the chloroform out for this one. This was an older case, and the Gutta-Percha was a little hard at the apex. I finally do get down it with R1, but this is our finding the MB2. You can see that little white dot right there. This is calcification. That's the actual MB2. As soon as I drop in there, you can see the pus come out. And then this one, I just used a 2006, and this just dropped down beautifully to the apex. So on this one, I didn't have to do too much work to actually treat it, and I was able to get the MB2 taken care of very, very effectively. Little bit more of a bend than you probably want to do when you're first learning how to do it, but you can, as you, this is a, say, do as I say, not as I do type thing, but as you get more and more experience, you can feel how the files are used. And I've used these files now for probably 4 years. So definitely, I know I can feel when they're starting to give. So yeah, any questions so far? I know we're getting towards the end here. Nothing? Was this helpful for you guys, hopefully?
Yes.
Good.
For the R1, when are you engaging the foot pedal? When you're pulling back up, are you just releasing the foot pedal and pulling upwards?
Great question. I engage when I move apically and then stop so that it has a chance to cool. And then you're using that barb to pull as you come out. You'll see on this one, there's this little fin on the distal where every time I use the F1, right here, see how that's off to the palatal? Every time I use the F1, it would pull up the Gutta-Percha, but then it would compact it into this stupid little fin. So on this one, I am using it the whole time as we're doing it. But yeah, you want to apically activate it and then do it there. And then this is pretty much the end of it. We run the gentle wave, and all said and done. That's what it looks like. So there's your MB1, there's your MB2, and that's what the final looks like. Nice little puff all the way down to the bottom on both of those, and you can see the 2 canals. Cool. That was fun. What other questions you guys have? I know you guys have a hard cutoff. I might maybe have screwed up the schedule and had to move a few things around. So I actually have some time. If any of you want to stick around, you can ask me whatever questions you guys have. It doesn't have to be at ultrasonics.
Thank you so much. We enjoy your YouTube channel.
Oh, good. Hopefully that's been helpful as well. It'll be up here on there.
Could you talk a little bit more about how you retreat thermafils?
Thermafils, great question. So with thermafils, kind of like a post. But what's happening there is the carrier is being held in place by the Gutta-Percha on the outside. Disclaimer, I don't think Thermafil is a bad material. I think it has a propensity of being used poorly because you've all seen this happen. They're like, oh, I'm going to use my Thermafil. Cool. And you place it and you take an x-ray and you're like, crap, it's short. So what do? You push a lot harder. And what you do when you push harder is you're stripping all the Gutta-Percha off, and now you just have this stupid plastic piece sticking out the bottom, and that's why it fails. Those are harder to retreat. The best Thermafil to retreat is when the plastic is just like floating in the coronal part. Usually I'll take the F1 down and that will rip the part out. So for the hard ones, what you're going to want to do is create a channel, and you want to create this channel on just one side. So if you have an oval shaped canal, you're going to have that carrier down the middle here, and you're going to have Gutta-Percha on either side like this. I usually choose whatever's easier to access, but only do one side. Don't go back and forth, because what you want to do is you're going to create a space down, let's say on this side, it'll be the lingual, okay? Create your space down. You can do that using the R1. You can do that using heat. You can do that using the F1. You can do that using whatever retreat file you want, but only do it on one side. Then you're going to take a headstrom that is just slightly larger than the space, or slightly smaller than the most coronal part. So I've used 15s and I use 55s. It's all between. You want to have like a variety of headstroms available. What you're then going to do is start to screw the headstrom in, and once you get endo hands, you can just pull it by yourself. But oftentimes you want to use like a most people will use hemostats to grab it and pull, but you then use a pulling motion, because what you're doing when you're screwing the headstrom down, the plastic carrier is softer than the dentin. So more of the headstrom flutes are going to grab the plastic carrier than they will the dentin. And when you pull, if it's too hard to pull, do a quarter turn back, pull again. If it's still too hard, do another quarter turn back, pull again. If it slips out too easily, you have too small of a headstrom go up in size. Now, the reason it's really important that you don't remove it on both sides is because you're using this Gutta-Percha here to support the carrier as you're screwing into it. If you do both sides, what you're now doing is making it so the carrier can flop back and forth, and it's very difficult to remove it. This technique works 99% of the time. This is what I use all day long. I redo a lot of Thermafils, and that is the best way by far. Once you get the carrier out, it's super easy. Usually there's going to be a ton of pus following after it, and you can just go back in with your regular retreat file and get the rest of it out of there. Good question. Did that answer kind of how to do Thermafils? I have a bunch of videos on Thermafils too.
Thank you.
Yeah. But yeah, big key, don't do both sides. Just do one. What other questions you guys have?
What file system do you use?
A combination of them, but the key thing here is to make sure you have an idea of why you're using the file system, what shape you want it to look like, rather than saying I'm going to use X, Y, and Z. So I use the Brasseler VT Scouts, and I primarily just use the 1704 and the 2006 for the vast majority of my cases. In that box right back there is a random smattering of files that I'll grab once in a blue moon. For most of my retreats, I will be using some sort of pro taper because they're very good at removing Gutta-Percha, and most of the time the size is big enough that I'm not removing any extra dentin. For certain anteriors, I see a fair amount of kids, and so I'll use pro tapers for those too, because like an F1 shape fits anterior and like an 8 or 9 really, really nicely. But yeah, that's what I use for the vast majority of my cases.
Thank you.
Yeah.
Can you go over your obturation technique?
So for those of you who don't know, I use an obturation technique, which is coneless. And so it's locally called the squirt technique, because that's what you do, is you just squirt the Gutta-Percha in there. It took me about 2.5, 3 years to finally feel comfortable using it all the time. And at the end of it, I said, I'm never going to teach this. And now I'm teaching it, so that's fun. How you want to use this is there's a lot of nuance to it. The perfect shape is kind of like that F1 where there's not, you don't want there to be a big finding at the apex because what you're relying on is the pressure that's naturally inside the bone from keeping you from extruding. So you need to place the sealer. I use a cone or a paper point to place it down to length. I then recapitulate, and this is really, really important. You cannot use the squirt technique if you're ledged. If you can, it will not get around ledges. I have problems sometimes with type 2 canal systems, depending on how steep they join up. But if you don't have an open patent canal, the air is going to stop and push you back out. You need to be patent all the way down to the bottom. So I always recapitulate with a 20K file with my sealer in there before I finish the case. Then you're going to take your obturation unit. I use the Beta from B&L, and I use it with their soft Gutta-Percha. I use it with the 25 gauge needle, which is the smallest one they offer, and I use it at the maximum temperature that the gun will go to, which is 230 degrees. You then place it down inside the canal until it binds, and you back up 1 millimeter. You don't want it to be completely bound inside there because that's how you get stuff shooting at the apex. You then start to squeeze until you feel it push you back up. At that point, you're going to come back in with a plugger. I use a nickel titanium 35 is the primary one that I use because it's flexible and so it can go around there. And then you're going to condense apically about 2/3 of the way, depending on the size of the tooth. This is why I said I'd never teach it because it's really hard to learn. There's a lot of, it depends on what you're trying to do. After that, you backfill it all up, and it's really straightforward. You will get a sealer puff every single time with this case. And so if you're in an area where they don't like sealer puffs, unfortunately, the director at St. Louis does not like sealer puffs, so the residents don't get to use this technique quite as much as they'd like. Be aware of that. But it's probably the best way. I mean, besides Thermafil, it's the only way to get heated Gutta-Percha to the apex when you think about it. Even a warm vertical, you're not getting it but more than a couple millimeters past the apex. With single cone, you're really relying on the sealer more than anything. That is one huge caveat. This does not work with any of the bioceramic sealers because they set up in the presence of heat, meaning you place your sealer, you go in, you do the squirt technique, and what happens is the sealer sets up immediately and you're 3 millimeters short. Ask me how I know this problem, and it's really fun to retrade a bunch of hardened bioceramic sealer. It does not bode for a good time. So I still use AH Plus for the vast majority of my cases. I will use BC in certain resorptive cases, I don't have many people starting cases, but every now and then I'll have to fix a perf, and I like it for that. But most of the time, I'm using AH Plus for that, for the reason of the obturation technique works with that, and it does not work with BC.
Thank you.
I told you I never. I told myself I'd never teach it, and here I am now teaching it to like multiple residencies. So this is great. This is
Are you
perfect.
doing most of your cases single sitting, or do you have?
What was the question?
Are you doing most of your cases single sitting?
Like single visit?
Yeah, single visit.
Yes and no. So my rule of thumb is if it's still draining, I'm not going to finish it. Trauma cases, I like to use calcium hydroxide for at least a month because it takes a month for the calcium hydroxide to get out to the outer layer. The basic environment helps inhibit osteoclastic activity as well as reform the cementum. And in most trauma cases, after you've done the root canal, what's going to cause that to fail? Resorption. So I want to stack the deck for them. And I see a lot of trauma. I'm the only one in Reno who sees kids. So I see a lot of kid cases as well. That being said, the reason I got the gentle wave in the first place is I realized I was two-stepping probably 2/3 of my cases. And this has allowed me to do a lot more single visit endo. But if it's still draining, even sometimes the gentle wave and a laser isn't going to be enough. I like predictability. That's one of the things I sell to my referring docs is that once it comes back from me, you're not going to have problems with it. And so I don't like filling cases that still are draining. When else? Yes, I try to one step most cases. I have found actually, I know this is a different company. Buy healthy products, they're great. There's my sales pitch for you. I know I've talked about you guys are this is the now free ask me anything area. But I didn't want, this is another case of me not wanting to like something because it's more expensive, but I got a bottle of Triton when it first came out after the AE in Arizona. And I'm friends with the rep, and he's like, you got to try this stuff. And I was like, I really don't want to. And he's like, no, trust me. I'm like, Mike, no. He's like, no, I'll give it to you for free. I was like, okay. And like I went through the bottle and I did the math. Like I'm a giant nerd. I literally did the Excel spreadsheet and I looked at, okay, how much is it adding per case? And it adds a couple of dollars per case to use it compared to using the traditional bleach EDTA isopropyl alcohol. And then it was my staff member who's like, but the bubbles are so good. It literally makes things look so much cleaner. And I do find that I'm able to one step more cases with Triton than I was with the previous one. So that started it. And then I was still two-stepping all of my retreats. And that's when I got the Gentle Wave. And now I'm one-stepping most of those unless there's still some drainage or if there's other considerations there. So I'd say I'm at probably a 20% two-step, and I think that's elevated just because of the nature of my patient population. It's more pediatric and it's more trauma-based.
Do you run Gentle Wave on every case?
No. Pick and choose. That's the problem when you get a toy like that, you want to use it on every case because you're like, I just spent a lot of money on this stupid thing, so I got to get my use out of it. I have found, and I found that it doesn't do well with carious teeth, and it doesn't do well with vital cases, which is fine because on both of those cases, I was one-stepping them anyway. Where it does really, really well is the nasty necrotic. You look at the cone beam and the sinus is completely filled. That's the cases that it excels at, and that's where I needed it. And it adds about $110 in the cost of the handpiece plus the extra stuff you have to use, all of that. It adds a little bit of time. Like that total retreat was, I think, 39 minutes from start to finish, and I didn't restore it for that doc. So that was just a traditional one. Whereas if I had done it open and med, I would have been done probably in 15 minutes with the beginning, and it probably would have taken me 10 minutes to obturate at the end. So it does add a little bit of time, but the benefit is that you don't have to see the patient back. And for this patient, she was driving from about 4 hours away. So very great use for the Gentle Wave to make it so they don't have to come back for a second visit. And so I found that there are certain cases that I don't like to use it on. Anteriors, I haven't found that it makes that much of a difference because with the really big infections in the anterior, most of them end up going to surgery anyway, even with using all the, I do decompression, I do all the fun different tips that you guys all know how to do. It doesn't seem to make that much of a difference. So my number one use is exactly what you saw it on. This is a perfect use. Patient from far away, great crown on top of there. We got some drainage. You saw the pus when I got into MB2. It made me feel very comfortable. Everything was super dry at the apex. So that's kind of how I handle the Gentle Wave.
Why don't you like the Gentle Wave for your vital pieces?
I'll probably just won't put this part on YouTube. Anecdotally, those are the most common cases where I see failures coming back. A vital case that all of a sudden after running the Gentle Wave is going to have, now all of a sudden you got infection, which doesn't make sense to me. It shouldn't. It should be cleaner. And it's not just me who has seen this. If you look at how the machine works, it struggles with vital tissue. It does really, really well with an empty canal chamber and getting into all the little nooks and crannies to kill the bacteria and the biofilm and stuff like that. But it struggles just chemically, like physics, with natural pulp tissue inside there. That's why you still have to go back and you still have to run through your files. You need to help the system remove all of it. And so I'm good friends with a bunch of the Gentle Wave people. And even they've said, like, you can't, if you have a wide open case, so let's say you just do your access, you drop in, theoretically, you should be able to build a platform, run the Gentle Wave, and it should suck out literally everything from top to bottom, including the coronal pulp, all the way to the apex. And what they've shown is that that doesn't really work. You actually need to help it out, remove a lot of the vital tissue to make it actually function. The other thing is I'm really big on the why. Why am I using the gentle wave? What's our success rate for a vital case? That's not rhetorical. I'm actually asking you guys.
Like 90-something%.
Exactly. So do you think I'm going to make it miraculously 100 by using the gentle wave? What's your success rate on a nasty necrotic retreat?
80%.
Yeah. 70 to 80. Do I think the gentle wave will push that up into the 90s? Yes. And that for me is worth the extra $110. It's worth the extra time. It's worth everything else to make it so that that case is more successful. I wasn't having problems with failures in my vital cases. I was having to two-step most of my nasty infected cases. And now this makes it a better experience for the patient. And it probably does help profitability by not having to bring them back. Math-wise, it's not that much to add in another patient because we're pretty efficient here. So it's about same, but it makes it a much better experience for patients, which is really important to me. And I see where I'm located in Nevada, we're kind of on the edge of a major city. And so I see people from 2, 3, 4 hours away regularly. And so if I can make it, they just have to make that drive once rather than twice. That is a huge value add.
Thank you. That makes sense.
Yeah. But it's cool toy. I think at this point, when you're out in the real world, you do need to have something for enhanced irrigation, even if that's just, healthy cells activator. And we know that makes things cleaner than like the endo activator. That's like your very basic level. The lasers, they work great. I am currently looking at getting a laser more for soft tissue stuff because I restore about 80% of my cases. And so it's really useful for that case. But they all work pretty much the same way. They make cavitations. They blow crap up inside. They make little explosions and kill the bacteria. They all work in a similar way. It's all the same PIPS design that came out, however many years ago. It's just been modified and made a little bit nicer. So you will want to use something. And if you're in an area that does, as far as like laser versus gentle wave, I know this is way off the ultrasonic topic. Sorry there, Hans. Lasers are great if you're doing a lot of restorative and dealing with soft tissue work as well as the hard tissue because you get the dual use out of it. Gentle wave is really good if what you mostly see is retreats through crowns, which if you're in a big city, you're going to be doing a lot of retreats through crowns. So I guarantee you the case that I just saw will be your bread and butter 90% of the time if you go to a major city, because that's what you're going to see is the dentist tried to do it. They missed MB2. You know how to find MB2. Learn how to find MB2. That's where the gentle wave is really useful.
How do you deal with fiber codes?
Mostly swear and get pissed off. That's where ultrasonics are super useful because, so with fiber posts, you're not relying on straight power to vibrate it out. So you back up. The technique we use to remove metal posts cannot be used on fiber posts because as soon as you take that big scary ultrasonic and hit the fiber post, it's going to shatter into a million pieces. So the only real way to remove a fiber post, sorry, I have braces and it's just been real fun learning how to talk again, is you have to drill them out. So this is where ultrasonics are wonderful because the way that I do this, I don't know if I actually have a video on this. Next time, thankfully, I don't have to retreat as many fiber posts in this area. The dentists tend to use metal, and so I tend to not have to do as much. But the way that I do that, remove the restorative material just like normal. And the nice part is the fiber post is usually a little bit darker than the surrounding composite. So you can see composite, and then, okay, here's the post inside there. This is where ultrasonics are really nice. You don't create as much heat. So it's not like when you're removing a metal post where you have to have a ton of water in there. You can do this dry. You're going to take something, and this is where the finder would be a really useful one. I'd start with the E2D and then finish it off with the finder, depending on how long it is. And as you activate down, you're going to be create a lot of dust. So this is why I have an assistant side scope, and my assistants have an extra long stropco that they use, and they can blow air inside the chamber as I work. What that does is it removes all the debris at the same time. So all that dust, if you were to do this by yourself, which unfortunately you're in residency, so this is what you have to do, you're going to activate it, probably run it for about 5 seconds before there's so much dust you can't see anything. Then come in, rinse it out, dry it, repeat. When you have an assistant and you have a side scope so they can see what you're seeing, they can keep the air in there, blow the entire time with the suction to suction out all the debris, and you can literally just tunnel right down the entire thing of it.
Thank you.
Yeah, they suck though. Oh my God, I hate removing fiber posts. Yeah, fiber posts suck. Thankfully, most of the time, I'm knocking on every piece of what I have. Most of the time, they're placed really poorly and they only go down like 2 millimeters. And so all the ones I've had to remove, they pop out almost immediately. Like I hit it with the ultrasonic and it pops out just like you saw the composite pop out. So they're done really poorly. That's the good thing. I haven't had to retreat any of my fiber posts, and I'm terrified if I ever have to. Like those will just be surgery because I place them 15 millimeters down, if not farther. So I don't want to touch those. Yeah. Good question. Fiber posts suck to remove. Very useful tool. I use them all day long, but they are a little bit more of a pain to remove.
Do you use water for all of your ultrasonics? Well,
Nope.
actually, you mentioned you don't. So do you ever use water?
Yes.
Okay.
So anytime I'm using something with a lot more power, then yes. Once again, go back to the why. Why do we use water? Is to keep things cool. So what are you doing? And is it going to heat up the tooth to the point that it can damage the surrounding area? It's like what, a 10°C increase? Like you can create if you've ever had to, like in my residency, we had to place a metal post and then remove it in an extracted tooth. And I remember like almost burning my hand because it got so hot because we weren't using water because we were doing it extra early. Like it gets really, really hot if you're using it at max speed. So I use water 100% of the time for removing metal posts. I use water 100% of the time for surgeries. And that's more, I don't want to leave any of that crap inside the crypt. So I want to make sure we're constantly flushing that area. So any of the, like if I'm removing the tip of it, I use the Blade Sonic from Helsley. That's probably the number one thing that I think I sold to the AE. And you want to use a lot of water for that. Also, it creates a lot of heat. So those are the two times where I'm using water 100% of the time. But like if you're using a really long skinny diamond at like 10% power and you're 15 millimeters down removing a file, are you going to be creating that much heat? No. It's only when you're going to be needing to cool things off that you use water. And when you use water, use a lot of it. You should be cranking that thing up. Want to keep it cool. Good question. Any other questions, guys? It's okay. I got more time. Like I actually screwed up. My staff thought we were. I told them it was at noon, and I usually teach the SLU residents, which, if you know your time zone, St. Louis is in Central Time, and that's only 2 hours ahead of time. So I actually blocked off my 10 to 11. Thankfully, my 9 needed drugs, so she's coming back this afternoon on Halcyon, and we're going to be seeing her then. So I was able to still make it all work. So I actually have more time if you guys want to chit chat. Otherwise, I'll let you guys get on to. Do you have patients right now?
Some of us do.
Okay.
Yeah.
For those who don't, let me know. You want to hang around?
You do surgery a lot? Do you do a lot of surgery?
Yeah. It depends on what you say is a lot. I'm not like Dr. Kim doing 8 of them a day, but I probably do 2 a month. Yeah.
Or
Yeah.
how many cases do you do a day?
How many cases do I do a day?
Yeah.
Well, let's see. What's my schedule look like? I mean, today, 1, 2, 3, 4, 5, plus 4 consults. I don't know. Usually 6 to 7 treatments with, we'll say 4 consults on the side. Kind of just depends. Yeah. We try to make it, we're pretty efficient here. I don't like to waste people's time. And so most of the time I'm only in a case for about 30 minutes. We all started off being a lot slower, so don't think that you need to be taking 30 minutes on cases now. What was the question? Were you guys talking?
Yeah, I think you answered it. She was
Okay.
asking if you do a lot of surgery, right?
Yes, definitely. So it's a very useful tool to have. Funny enough, I actually did more Apicos in dental school than I did in residency, but that's a UOP thing, being insane like that. So and then I did a GPR that was very, very surgery heavy, like oral surgery heavy. So I'm very comfortable with surgery. I don't do any mandibular molar surgeries anymore because pretty much on recall, every single one of them is broken. And we use the same technique. We keep things nice. And I don't know what it is about those, but something about mandibular molars, the surgeries just aren't predictable. And I think that's probably the easiest area to place an implant in. So we should just do implants in those cases instead. My surgery fee or my retreat fee is about the same price as what the placement of the implant would be. I share the office with a oral surgeon. He's been looking. I forgot to tell him I was lecturing today, so he's been looking in here like, "Can I get my coffee?" So I constantly ask him kind of what his prices are for everything, and so we keep it a little bit under that. But I want it to be my as far as predictability. I want everything I do to last for at least 10 years. And if I don't think it's going to last for 10 years, I'll talk to the patient. And if I think it's going to last less than 5 years, I'll usually recommend extraction at that point because I want what I do to last. That's what we do is expensive and you want to make sure you're giving that value to the patient. And if it just breaks within a couple of years, you didn't do much value to them.
Do you try to remove cast posts?
Once again, another really fun one. Yes. Okay. Cast posts. It's really easy. Cast posts actually are pretty easy. What you do from cast post, you're going to have the entire core on the top with that little post shoved down there. So what you do is you create the coronal part, you make it into a regular post. Then you just take it out like normal. They're actually not that hard. It's annoying because the metal they use is usually really, really, really tough. And so you're going to go through a bunch of metal cutting burrs when you do that. So yeah, I use the SS White Piranha, I think is the name of them. That's like a family of them, but it's the little small gold ones. Those are probably the best for moving metal, but you will go through probably 4 or 5 creating a post out of the cast post. You have to make it like that. Cool. Any other questions, guys? You have my contact info. Feel free to reach out. Join the Discord, ask questions. It's okay to not know things. I still ask questions all day long. I feel funny talking to people because I feel like I still don't know anything. Cool. Alrighty. Thank you guys so much. Anything else, Hans? We all good?
Yes, we're all good. Thank you so much, Dr. Scott. It was amazing, and everybody enjoyed themselves in here. Yeah.
Beautiful.
Yeah.
Thank you guys so much. If you have any comments about the presentation, please let me know. I'm always trying to make things better, so don't hesitate to reach out if you think I could have done something better or rushed through something. I'm always here to hear improvements.
Yes, and you did mention you were going to send your presentation over to them. So if you do send it to me,
Is that the best way?
And then forward it over to them.
Okay. I mean, if you're okay with it, I'll just drop it publicly on YouTube.
Yeah.
Cool.
Yeah,
All right.
good
I'll
with
just edit this up and clean up a few things, and we'll drop this, and they'll have my next video will be how to use ultrasonics, along with a very long AMA.
All right, thank you, Dr. Scott.
Thanks so
Enjoy
much.
the rest of your day, and
Yeah.
we'll definitely catch up after.
Okay. Have a good one. Thanks, guys.
All right.
Bye.